Okay, the next thing we want to talk about is dementia. And as I mentioned earlier, as people with intellectual and developmental disabilities live longer, particularly people with Down syndrome, we're seeing a huge increase in the incidence of cognitive impairment or dementia. It creates a lot of complications for managing in the community and for caregivers and for the individuals themselves.
Okay, so what is dementia? Dementia is a group of symptoms that accompany certain diseases and physical conditions, a loss of intellectual function severe enough to interfere with your activities of daily living. It affects your memory, it affects thinking, it affects language skills, judgment capabilities, and behavior. The cause and rate of progression of dementia varies depending upon multiple factors, which we're going to gradually look at through the next few slides.
So how do you know when somebody is experiencing changes that may indicate the beginning of dementia? One of the things is that they may complain about memory loss, but they're not really able to recall occasional forgetfulness. Sometimes they might search for a word or a name. They might just not remember, somebody's name, even though it's somebody that they know really well, a familiar person. They may get lost a lot. They may have to think about directions, but
these are normal memory changes.
These are normal memory changes, but they don't get lost in familiar places. They remember important events. Maybe they have to take notes in their calendar more frequently, but they're able to carry on a conversation. They're able to remain socially aware and to pursue relationships that have been important to them.
So take a look at what's a normal memory change first. Because we're all aging, and it's not uncommon. I can't say I'm not guilty of it. I have to use the beeper on my car to find my car because I forgot where I put it in the ShopRite parking lot. These things that just happen, but I'm aware of how to find my car. So some things are normal memory changes, or some things are you forgot to do something. You have to write yourself little notes because you're working still. You have a busy day. You have a lot on your plate. So it's very common to just forget something. That doesn't mean you have dementia. Okay, memory changes in dementia we're going to talk about next.
Okay, so these are the person may complain of memory loss if they're asked, but they don't really recognize that they have a memory loss. So if you say, gee, it seems like you're getting more forgetful, the person might say, well, yeah, I guess so. But they wouldn't bring it to your attention. They wouldn't say, you know what, I had a senior moment and I don't remember where I put my keys, because it's really out of their awareness. They have trouble finding words. And one of the things I think that's really remarkable when somebody is beginning a cognitive decline is they'll ask for something by the function, not by the name. So if they want a drink of water and they're looking for a glass, they'll say drink. They won't say, where's the glass? Again, they get lost in a familiar place. They may need extra time to get home. They may become confused when they're outside of their home environment. They don't really converse as well. They lose words. They can't really remain active in a conversation. And they may begin to behave inappropriately. You may see some acting out, some agitation, even some aggressiveness in someone who used to be very easy to get along with and very, easygoing, social, and fun. You'll notice at the bottom of these slides, we've given you a resource, a helpguide.org/Alzheimer's. A lot of the information that we found for this presentation was available there, as well as some of the information that we're going to use. It's full of resources, and I highly recommend looking at it.
Some of the common issues associated with dementia that you're going to see is just a reiteration of some of what Jill touched on. The memory loss, difficulty completing multi-step tasks is common. All of a sudden, if it's not a simple task you're doing and it needs several actions to complete, they get mixed up partway through. Unable to navigate previously familiar places. All of a sudden, this person that always just took themselves to the bathroom now can't remember where the bathroom is. they want to go to bed at night and they somehow manage to get into someone else's bedroom by mistake because they really are just not able to remember where their own room is. So when you start to see things like that, that's something that would be clues. Reduced judgment skills, personality changes, and a loss of social skills like Jill was discussing. Taking longer to do more difficult mental tasks, like I was saying with the multi-step task. And language problems, such as difficulties with names of familiar objects, as Jill was saying, is what you would see more of.
And I think one of the things to point out is that if you're working with someone who has Down syndrome, you may begin seeing these things when the person is very young. They can start as early as 35, and it can be very accelerated. You may see early symptoms, and within a very short time, you can see somebody really advancing very rapidly through the stages of dementia. So it's important, as we've been saying, to have a baseline of who the person is and to be really alert for these changes, and I think also to do some differential diagnosis to rule out that it could be a reaction to medication or it could be depression over the loss of a loved one. It may not be dementia.
Or a medical problem. I mean, so you want to look at all the varying possibilities. The other thing we had that we took from the help guide, the website that Jill just mentioned, is a little self-test just to give an idea of what kinds of things you start to look at. You can download that test yourselves at some other point. I don't believe that was one of the things we did as a PDF. So the questionnaire is not a definitive guide. It's just an indication that there might be a problem. It's a test that you can run on yourself, on a relative, on one of the people on your caseload, based on what their skill levels are. And some of these things are things you'll notice. Some of these things are things that you can ask. And the kinds of things you look at are the same things we were discussing. You're going to look at memories. In the self-test is a section on memories, and the kind of thing that you would look at is, does this person have a memory loss? And it's a yes or no answer. Has this person's memory worsened over time? That's why you need the baseline, so that you can judge that. Are they not remembering things that they commonly remembered? Are they forgetting that it's 11 o'clock and they always watch the news at that time, and all of a sudden they don't remember it's 11 o'clock or it's the news time to watch? Does the person repeat questions, statements, stories over and over again because you give them the answer, but they don't remember that you gave them the answer? They just keep repeating that question. Have you had to take over tracking events and times and appointments for that person? Does the person misplace items often? How often? Things like if they needed their keys, they put the keys to their house in an uncommon place. Like normally they always had it in the little dish next to their bedside, so they knew where they were, but all of a sudden now they can't figure out where they put it, or they're putting it in unusual places like the refrigerator. Does this person start hiding or stealing items and stashing them away? All of a sudden they need to, they start to think paranoid kinds of thoughts, like someone might steal my favorite tea, so I'm going to hide the tea bags, but then they can't remember where they put them. Orientation questions are some of the questions on here. Is this person unable to find their way around familiar places, yes or no? Is this person getting confused when outside of their home and they're having to travel to somewhere else? They mix up what the destination they're heading to is. Functional ability declines. Do they have trouble? If they were able to handle money at one point in time, are they now suddenly not able to make simple change? Was it someone that had the capability to do those things and now that capability is gone? Do they have trouble taking their meds if they were able to do their own medications? Do they suspect you of giving them poison because now you're giving them a medicine and they're not remembering that they used to take it, and they get suspicious? Other kinds of things you're going to look at is visual spatial ability on this little self-test. Are they lost in familiar surroundings is another kind of question that's on here. Do they lose their sense of direction? Are they suddenly unable to visualize going down the steps? Maybe you have to have better lighting because they're not able to visualize that there is a step they're taking. They lost their depth perception. And language, has their language skills changed? There's a little scoring to this. If you have time, take the self-test, see what it's like. See how it fits into your caseloads on who you're taking care of as ways of evaluating someone before you head to a doctor. And then as you do that kind of a self-test with yourself or someone, it's an indicator that, yes, it's time to go see a doctor and do further testing, or is this just simple aging, normal memory loss?
And I think just even being familiar with this test will help you to start thinking about those things. I know, as we were working on this and I started reading this, I began noticing among the people I was with, I began thinking about, well, gee, did this person always need reminders around this issue, or is this something that's new? So it brings it into your own awareness as a practitioner so that you can be thinking about it. If you see a lot of issues that are a concern, you might want to complete this on a person you're working with. Even if that person is 38, 39 years old, if they have Down syndrome, you really could be seeing the beginning of Alzheimer's disease.
Now let's look at the chart.
So this is just kind of a comparison of what would be considered a normal memory change. You can't find your keys. Linda can't find her car in the parking lot. I can't ever find my keys, so I just keep them on a hook, and it solves a lot of panic in the morning. But as we mentioned before, somebody with early Alzheimer's might put their keys in a strange place. Instead of putting my keys on that hook, which is next to the refrigerator, I might put it in the cheese drawer in the refrigerator, or I might put my wallet in the dishwasher. Again, a normal memory loss associated with aging might be, you forget a few names, you haven't seen somebody for a while, you can't remember their name, you have to ask. Somebody with early Alzheimer's is going to forget the names of people they know really well. They're going to forget the names of common objects, and they're going to change the way they use words. They may want a spoon, and they may just say eat. Another one is forgetting conversational details. We all live in a routine that's very demanding. We have a lot of things we have to remember, so it's common to forget something that you heard in a conversation that you had with somebody. It may have been very casual, even a serious conversation. You may forget some of the details, but you don't forget the entire conversation. Somebody with early Alzheimer's may forget ever seeing the person, ever discussing something with the person. Again, the getting lost is a big indicator. Somebody with mild, normal age-related memory loss, they may take an occasional wrong turn. They may have to think before they drive to a place they haven't gone to for a while. Somebody who has early Alzheimer's is going to forget how to get home from the supermarket that they go to every day. It's going to become, a big issue for them. And again, this is from that help guide for Alzheimer's disease. It's a very helpful website with a lot of information and a lot of resources.
I would go over a few other things here, like, it's normal to feel cold as we age. We're more sensitive to cold. But someone with Alzheimer's, what you would see is they have your seasons wrong. They want to wear shorts in the winter, and they're looking to wear an overcoat in the summer. Those are indications of Alzheimer's because they're not recognizing the difference in seasons. And feeling occasionally sad is a normal aging change, but big mood swings, going from tears to rage is an indication of Alzheimer's. This is, again, we're going to just reiterate this, the same things we just discussed. Functional capabilities change in dementia. Person loses skills in areas where he or she used to function well. The person may may need a longer period of time to respond to a conversation or a situation to focus on it to assess what you just said. Personality changes may occur and can lead to depressions. Persons may not be able to find favorite objects or their favorite clothing item that they would like to wear. A person can become easily upset, confused, or short-tempered.
And again, with somebody who has a disability, this is a loss of skills the person previously had. And it's important to make that distinction when you're working with a person. This is somebody who used to be able to speak very well, used to be able to carry on a conversation, and then you're seeing a decline in that ability. Or somebody who used to be able to dress themselves independently is suddenly having difficulty figuring out what part of his body his pants goes on. So it's a change in the current level of functioning. It's a change in the baseline.
Right.
And again, with people changing caregivers, it's important. We can't stress this enough. That's why we keep going over it and over it again. You need to really document what the person can do, what the person has typically been able to do, what skills they've learned and achieved, because as they age, they may begin to lose those skills, and you're going to want to be aware of that.
Some more changes. Some of these changes can become severe. A person may become paranoid or distrustful of familiar places, familiar people, familiar activities. Sudden mood changes leading to an explosive emotion or aggressive behavior. As Alzheimer's progresses, these are the kinds of things that you would see. Disorganized and frustrated when unable to find a favorite object. A person losing language skills.
And I think one of the things that's probably the most tragic about watching somebody with Down syndrome or an IDDD experience dementia is many times they have struggled for their entire lives to achieve these skills. And then to the extent that they're aware, they're watching those skills sort of disintegrate. And it's, you know, I think a lot of them become very depressed, and it is very, very frustrating. And it's frustrating for caregivers as well. And when you're working with somebody like that, it's important to keep that in mind. They may be, you know, it may be very difficult and frustrating to work with somebody who repeats the same question over and over again, or somebody who has very aggressive behaviors when they used to be very easygoing. But that's that person's expression of the loss that they're experiencing, and it's their tragedy that you're watching and that you need to support. So what can you do? How can you support this? You want to learn about the differences encountered when working with people with IDD and dementia. You want to help them maintain their connections to others and in the community. When we talked about graceful aging and you know, preventing a lot of the onset of aging, we talked about how important social connections and relationships are, and how important it is to continue to stimulate your memory and your mind. So you want to provide ongoing opportunities for that person to continue to be engaged and active. If the person is working or the person has daily activities that he goes to outside of his home, you want to really encourage and provide the supports to enable the person to continue to do that. Because the more the person is stimulated, the more the person's engaged, the longer that person is going to be able to maintain his or her ability to function within his home and within his community. And by community, I mean not just, you know, his neighborhood and the town he lives in, but that community of people who are his friends and family. You also want to seek out resources that will help you design activities for people who have dementia, things that are going to take into consideration their declining skills, but that are going to continue to stimulate them, encourage them to keep the abilities that they have.
Okay, questions?
No questions at this time.
So we have no questions. Should we give a few seconds for people to?
Sure.
Yeah, I can give a chance.
Again, if anybody has any questions, please feel free to type them into the chat window, or you can use the raised hand feature on your control panel, and then I can unmute you and you can ask your question.
So is anybody typing in questions? Okay, I'm going to go ahead and go on. If things do come up that you have questions about, please go ahead and type them in, and Lisa will pick them up. And we'll have one more question and discussion period at the end of the presentation. So what we're going to talk about now is supporting the person's choices. And this is something that you're doing throughout the person's life, but that support should not diminish as the person ages. So you still want to work with the elderly people to help preserve their autonomy and their self-determination. One thing that aging doesn't change, it doesn't change who the person is. So it's important to develop supports that are going to help the person continue to be who he is and who he wants to be. Some of the valued outcomes in aging are you want to maintain your physical and mental health. Somebody with an intellectual disability wants that same thing. They may have difficulty expressing it, but if you work with them, you know, you'll find in most cases that the person wants to continue to be active. They want to continue to feel good. And they want to be able to remain engaged. You know, they want to be able to see their friends. They want to be able to work when they have jobs. They want to be able to pursue interests, crafts, hobbies, whatever. And they want to continue to be part of their community. They want to go to church. They want to go to the library if that's something that they've been doing. They want to continue to see their families, participate in birthday parties, holiday celebrations. You know, in other words, they want a real life. And a valued outcome in aging is to preserve those aspects of life that are most enjoyable for the person, even as he ages and experiences disabilities. Something we hear a lot about is aging in place. And what that means is that people have the environmental and care supports that make it possible for them to remain in their homes and involved in their daily work and recreational activities safely as long as possible. And the safety is a huge concern, particularly when we're talking about people who may be in wheelchairs, who may have seizure disorders. Safety becomes a huge issue as those individuals age. So you want to consider how to make this possible by looking at the supports across the board, taking a very holistic view of what you're providing, both at home and in the community. And you want to consider the person and his or her lifestyle from this perspective of looking at the entirety. Environmental supports are huge. Is it possible to modify the residence the person is currently living in to minimize risks? Is there a downstairs bedroom that would be more safe for that person than the upstairs bedroom? Do you need to change lighting in the evenings? You know, what other supports can be provided to help the person stay in that particular home? Is the person's work environment safe? If not, what kind of accommodations can you advocate to be put into place for the person? A lot of times in my experience, and I think Linda would agree, you know, people may not realize that the person is aging, particularly if you're working with the person very, very frequently, seeing them maybe once a week or once every other week. Somebody who doesn't see the person as often or doesn't see the person at home may not be aware of the changes that are going on. If you bring them to the attention of somebody in a workplace, they're more than happy to work with providing environmental accommodations. Travel. If the person is used to traveling and they have the ability to take a bus or in some cases even to drive, make sure that the supports are available so that they can continue to access transportation. Is it possible to obtain a van that would accommodate a wheelchair if somebody has recently become non-ambulatory? Many buses provide supports for people who are using walkers or wheelchairs. The biggest piece of this is training. You want to make sure that the individuals and the caregivers understand the implications of new needs that are emerging and how to support these. So you want to help them to be alert to new changes, new needs, possible med reactions and side effects. You also want to be observant and aware of how the person is coping today. You know, you want to be aware of what's happening today so that tomorrow you're more likely to notice if there's a change. It's a kind of a constant vigilance, I think, when you're working with someone who's aging. And you also want to provide information to people and caregivers about what dementia is like, what the implications are, and what kinds of signs and symptoms they should be aware of. You may want to share the AIMS test or the dementia test with people who are hands-on providers of care to people so that they're alert to those tiny subtleties. And not that those can be used for a non-professional to diagnose, but they can be used as a source of information, and then they can bring what they see to the attention of the nurse or the physician so that further tests and evaluations can be done. So self-determination is something that we've heard a lot about, and in general we hear about it with young people and young adults. But this is also something that applies to people who are aging. They still want to be who they are. They want to have a real life. They want to be able to exercise the same rights that all citizens exercise. They want to be able to vote. They want to be able to go out into their community, enjoy a movie, go out to eat. So they want freedom. They want to have some authority over their resources. Now, if somebody is experiencing dementia, they may not be able to actually manage their funds, but they want to be able to have some choice over where they live, over the kinds of things that they do. They want to have the supports they need to exercise that authority. So they want you to interact with them in a way that you're listening to what they're saying, you're hearing what their needs are, what their dreams are, what their personal goals are. Even if those goals are for a very abbreviated amount of time, they're still important to the person. And they want to be responsible. They may not be able to manage their funds anymore, but they still want to be an important part of their community. They still want to be able to contribute money in their church on Sunday, or they still may want to volunteer if they've been volunteering with children or at a nursing home. And when somebody is self-determined, what that means is when they talk about what they want, it's listened to and it's supported so that they're able to go ahead and put things into place that make their goals really achievable and attainable.
I have one thing I just wanted to add on self-determination. I mean, people have, sometimes we forget that, everybody has like their own ideas of what life should be like, and circumstances sometimes change, and it's important that we know routines for that person. Like I was just thinking of a young man with Down syndrome that resided with his father, and he had a routine set with his dad about when was breakfast, when was lunch, what time you go to bed. He went to bed at 11 o'clock after the news was finished. Then he knew that was bedtime. He couldn't tell time, he couldn't read, but he had some real clear, self-determined ideas of how his day should run. Well, Dad got sick. Dad had to go have surgery, and his sister ended up being the person that he temporarily stayed with while Dad was in the hospital. And their routine in that house, they never thought about what Jeff's routine was. What they thought about was their routine was at 10 o'clock, it's bedtime, everybody goes to bed. Well, he was a quite determined young man, and he looked at the clock, and he looked at the television, he said, well, the 11 o'clock news is not on, so I'm not going to bed, because my time to go to bed is at 11 o'clock. And she had to eventually concede and allow him to stay up till the 11 o'clock news was finished, because he was so self-determined that this is what he wanted, that he was going to exercise his right to make that decision and go to bed after 11 o'clock news. And it was useful for her to actually know those things prior to taking her brother in with her, because it made a little dissent, essentially, until she finally had to accept the fact that this was his routine, and he was not going to change his routine because his life suddenly changed temporarily.
Sounds like he was also a really good self-advocate.
Yes, he was.
And I think what you bring to mind, Linda, is that when we're trying to provide supports to somebody with ID or GD, we may have our own ideas of what that person needs or wants, but we don't really know unless we ask them what they need or want. I think, looking back, to the dark ages when I was initially writing goals for people, a really common goal was something like, John will be compliant with taking his meds. Well, if you think about it, that really wasn't John's goal. John may have been willing to take his medication if it made him feel better. He may have wanted to take an analgesic for a headache, but his goal in life was not to take the medications that somebody else gave him. And I think it's important to support not just what a practitioner may identify as being useful or important to the person, but what that person is identifying for himself. And I think by doing this, you're also supporting a healthy aging process because the person will be happier. So how do you assure person-centeredness and self-determination? As I was saying, you really want to support individuals to talk about what they want. And as somebody ages, it's a good idea to talk to them about what their thoughts are about aging before it becomes a crisis, before they have to move out of their parents' home and into a different living situation, or before they become very ill. You want to really know what that person had in mind for himself, and you want to document it. Some of the things you want to talk about is, where would they like to live? Do they want to try to live in their own apartment if they're capable, physically capable as they age? Who would they like to live with? Do they have a best friend? Are they happier living with somebody who's a roommate, or would they prefer to live in a situation where they had their own room? And don't be afraid to talk to them about the realities of what they're confronting. People who have intellectual and developmental disabilities have a lot of ability to understand what's going on around them. They have a lot of abilities to understand their situation. It may take longer for them to get a sense of what the implications are, but that's where your role comes in. Talk to them about the barriers. Talk to them about what it means to have parents who are aging and can't provide care to them. Explore their sadness over that loss. It's not a secret that things are changing. You know it, and the person knows it, and it's really important to get it out there and look at it. Help the person to identify alternatives. If they always wanted to live in an apartment on the top floor, but they're not able to walk upstairs anymore, what would a good second choice be? What would help them to feel comfortable in their living situation? So where would you begin, Lisa, in doing this?
Well, first we have to demystify the aging process through conversations with the person and caregivers. Talk about how aging is affecting individuals, changes in appearance, health, stamina, thought processes. Initiate discussions around the individual's wishes for developing new supports or living arrangements to manage age-related needs. Like this young man that ended up temporarily staying with his sister, it was not his ideal choice, but we had to sit down with him. We had to explain to him that Dad needed surgery, Dad's aging, and eventually we also had to find him an alternative placement because his sister was not able to keep him in her home. And it was not going to work between their routines. So we had to look at alternatives for him. And they weren't his choices, but they were alternatives we had to sit down and work out with him. Like I said, initiate discussions around the individual's wishes and living arrangement needs. Encourage caregivers to discuss their concerns and plans honestly and openly, which is something that we did with Jeff's dad. He knew he was aging. He knew he needed to have a plan for Jeff so that he could go on with life beyond his dad. And that was a possibility that eventually came around. Some of the topics you want to discuss. Where do you want to live? In a small house, with family, with friends? What things are most important to you where you live? Do you want your own room? Do you want to have familiar people around you? Do you want to have access to shopping? Do you want to have TV available? Do you want to be able to get out to the movies once in a while? What do they do for trips in the residence you're living in? Who are your closest friends? Where are they located? Can you live with them? Can you be near them? It's a big loss to lose the friends and family that you've always had around you if suddenly your living circumstances change and you're no longer able to stay in the home you're used to living in. How important is it for you to have people visit you, to keep in touch with you? Ask questions about what other kinds of things do they like. Do they like music, crafts, video games, concerts, movies? What do they want to do? What do they want to be kept into their lifestyle? What do you want to do during the day? Do you want to continue to work? Do you need supportive employment? Do you need to go to a day program of some kind?
Want to have a retirement plan and go to a senior citizen center.
Yes. And those are all things to bring up. The other conversations that we want to bring up is with caregivers. As caregivers age and they may no longer be able to provide a previous level of support, what's the plan? What are you going to do? Sometimes it's just not thought about until too late, especially someone who's living in the community with an aging parent. All of a sudden that aging parent is no longer able to provide the care. What happens to that person? Where do they end up going? I have one person that comes to mind. I mean, her mother, she lived with her mother. She was in a mild range of intellectual disability. Mother's plan was that she had an account set up for her so that she could stay living in the home she had always lived in. But she never really worked with her on how to manage money, how to manage paying for electric bills and food. And those are things that were never planned on or discussed. So ultimately that person ended up not being able to stay living in that house, and it created a long period of depression for her because she wanted to have her home. She wanted to stay in what was familiar, but there was no one there to take care of her anymore. And just setting aside a money account to manage things wasn't adequate because she didn't have the life skills to manage that money or that household. Encourage family caregivers to identify their personal goals for retirement and health care. You need to discuss their plans for their family members' care, who will care for that person in their absence. Like the father that just assumed his daughter would have no problem taking on her brother's care, but she did. She had young children of her own. She worked part-time. She had a household to run. And Jeff took more time than she really had to give, but they never really had that conversation while Dad was still alive. And ultimately, Jeff ended up going off to a placement that ended up upsetting him until he adapted finally. Those are things that could have been avoided. If you could have taken him to the home that he was possible for him to live in. Look at other choices besides living with his sister, who didn't know how to say to her dad that this is not something I want to take on as my job. Those are things you really should be discussing, because maybe someday it's going to look like it became your job and you can't do it. What's the alternative? Is there a group home? Is there a caregiver somewhere in the community that's going to take on that job? Because he didn't have the skills to live by himself or on his own.
He may not have wanted to live by himself either.
Right.
I mean, loneliness and isolation are huge issues as well.
Help family caregivers develop a wish for their family member and help them to prioritize and actualize those wishes. And it has to be a practical plan. Can this really work? It's not. It may be what you wish for someone, but can it really work? Is it feasible for that person to live in a home on their own? Is it feasible for Jeff to live with his sister? Those conversations should have been happening, not when Dad passed away. Collaborate to identify community resources to make their plans and wishes a reality.
So, and by including the person in those discussions, you're really supporting that person's autonomy and helping him to take ownership of his own life, which is something that for people with IDDD historically has not happened, where they've kind of traditionally been discounted when they really are capable of learning to advocate for themselves, learning to make very good decisions for themselves if they have the tools and the supports to consider those decisions, from a variety of different perspectives. So how can you do this? You want to become as knowledgeable as possible about the aging process for people with IDDD so that you're aware of the changes that you're seeing in people. And you want to be able to have the time to really explore and discover what it is that's affecting a person at a given time. Is the person beginning to show signs of dementia, or is this a drug reaction? Is this something that can be managed and changed, or is this part of the aging process that's going to just go forward kind of on its own inertia? You want to be aware of the supports for aging in your community. There are many, many supports being provided through state and federal programs right now. I'm sure you all are all aware of the Medicaid HCBS waivers, the home and community-based waivers. There are contingencies built into those that support aging in place for the elderly in the community. You want to become knowledgeable about those. There may be opportunities provided in your state that you're not aware of, but that would be really useful and would make a huge difference in the life of somebody that you're working with. You want to develop partnerships with community health care providers. And I think that's something that, in our experience, Linda and I have found to be tremendously important. People with ID and DD, they may not be known to healthcare providers. Healthcare providers may not have an area of expertise within their practice that's going to give them the knowledge to really address very specific issues around somebody with Down syndrome, somebody with Fragile X. There's that tragic story that Linda shared with us about the woman with Prader-Willi who really ate herself to death in a hospital surrounded by medical professionals because they really weren't aware of that whole issue around food that people with Prader-Willi experience. So partner with healthcare providers, develop a network of providers who are dedicated to working with people with ID, DD, and who want to learn more and who want to consider new and important ways to support them and to help enhance their quality of life. You want to include the individuals and their caregivers in conversations around aging. Aging isn't something that we look forward to. Like as my dad said, as I said earlier in this presentation, aging isn't great, but if you consider the alternative, it's not that bad. So talk about aging. Talk about what's happening. It's fine to bring a little humor into it because it's something that everybody experiences. We all age, whether we have an intellectual disability or not. Aging is something that just happens. And by including individuals and caregivers in those conversations, you take away the fear and the mystery that's around it. You say, look, this is what we're dealing with. How can we make it work for you? How can we think about what you want and help you to achieve that as you grow older? And in those conversations, you want to find out what the person's wishes are. You want to find out what that person is hoping for as he grows older, what things are important to him right now that he wants to preserve. It may be really important for him to take a daily walk to the pond nearby and feed the ducks. How can you keep this in place for him as he grows older? Will he need a wheelchair? Will he need to be able to get a ride because he can no longer negotiate on even pavement? All those things are important as part of your person-centered planning process. And what you're doing when you're working with a person from this perspective is that you're really protecting their autonomy. You're protecting their personhood. You're going to do this by documenting what the person identifies as most important. And again, this is a baseline, but it's not just a few words. You want to make this a very comprehensive description of who the person is, what the person wants, and you want to be able to share this information with the people who work with that person in addition to yourself. So you want the person's doctors to know about it. If he goes to a particular medical practice, you want the nurses there to know about it. His caseworkers, even his family members. Sometimes when people live outside the home and they only see their family members maybe once a week or once a month, that family member may not be aware of what the person's hopes and dreams and personal goals are. And again, consent is an issue. You want to make sure that the person is comfortable with you sharing these things with other people. If you can get the person to participate in talking about what he wants with his doctor, with his day program providers, that's even better, because by doing that, you're empowering the person. You're saying what you want is important, and we're listening to you, and we're going to work with you to achieve it as much as possible. You can't, none of us can have all of our hopes, wishes, and dreams fulfilled. But if we have people who hear them and who help us on our journeys through life, that in and of itself is of tremendous value. So you want to develop partnerships and alliances wherever and whenever possible. So share that information. To talk about what resources, there are. If you're, talking with people from a day program, they may know of things that you aren't aware of. They may know about resources in the community that have worked for somebody who is struggling with a similar issue. You and the person can go investigate that. Maybe it's a day program for senior citizens that has a lot of music and the person loves to sing. And that may be a lot more enjoyable for him than what he's currently doing. So you want to make the person's continued autonomy a priority. You want to protect the person's personhood, because even though the person's getting older, even though the person is experiencing age-related changes, these are things that are happening to the person. It's not changing who the person is. So in doing this, advocacy is essential. We've tried to talk a lot about how people with intellectual and developmental disabilities may struggle with communicating. And maybe just like out of habit, out of a historical basis of never being asked, what do you think about this? What do you want to do? So you want to be aware of how the person communicates. You want to know, like, if that person has a certain facial expression, maybe that means they're in pain, or maybe it means they're not understanding what's being said. Sometimes it's really helpful, if you're talking with a doctor and that person's in the room. Doctors may sometimes not talk directly to the person. I mean, they may not talk directly to a patient. Even if that person doesn't have an intellectual disability, they may just talk to the caregiver. You might want to say to the person, so tell me what you understood from that conversation. Is there something about that you don't understand? So by advocating with that person, you're kind of encouraging them, saying it's okay to say what you think. Let's hear what you say. And you're supporting them to communicate the way they're most capable of communicating, even if it's slow speech or hand gestures or even just facial expressions. You want to be aware of what the person can do. What are his capabilities? Can this person feed himself, or does he need an assistive device to be able to scoop food from a dish into his mouth? Is this person able to say to somebody, I need to use the toilet, or is this something that he may need an assistive device to do? Is the person able to dress himself? Does he need help with buttons? Does he need help with zippers? Does he need to be fed? If a person is hospitalized, this is something you want to bring to the attention of the people who are caring for him. Does the person have a special diet need? I know we're going to talk in a few minutes about some of the people we've worked with. Somebody who may not have teeth may still be able to eat food that's not completely pureed. You want to know, do they like their food pureed, or do they like a little more substance to it? What do they prefer? Are they a vegetarian? Do they not want to eat any meat? These are things that a person with IDDD may not be used to advocating for themselves. They may just sit with something they don't want to eat in front of them and just not eat. What does that person need to feel safe and confident? Is there something, do they like a light on in their room at night? Do they like to go to sleep with the TV on turned low? By knowing these things, when the person is in a new situation or the person is experiencing a new health need, if you can provide these things, you're going to make the person feel better, and you're going to promote that person's recovery and continued health. It's also important to be aware of public initiatives and resources for aging individuals. We have the Affordable Care Act. You can go online. You can look at some of the accommodations that are provided in there specifically for people with intellectual and developmental disabilities or lifelong disabilities, as well as supports for the aging. The Affordable Care Act includes supports for people who need habilitation supports. So, look that up, get some information about that. Be aware of what your state's Olmstead plan is. The Olmstead decision supports progressive integration of people. People should be living in the most integrated setting, and that's promoted throughout this country, the closing of large institutions, and it's also promoted supports for people to remain in the community. Find out what aging supports are available for senior citizens in your community. Just because a person has an intellectual or a developmental disability does not mean they can't benefit from those services, and they continue to be eligible for them as well. It doesn't preclude their ability to be part of them. Aging and Disability Resource Centers are a collaborative effort between the Office of the Aging and Medicaid, and they are available all in different locations. You can go in and they'll provide you with additional resources and supports for developing services for people who you're supporting who are aging. Keep yourself informed. You know, when Linda and I first started practicing, there was hardly any information out there about people with intellectual and developmental disabilities, and just about none for people who were aging with these lifelong disabilities. But now there is just there's just a wealth of information that you can find. So look at state and federal websites for information on resources and funding. You can also look at the University Centers of Excellence for developmental disabilities, and you'll discover more information than you could even imagine is available. So at this point we get to the fun part where we talk about some of the people we've worked with, Linda. We're going to start with Daisy, and I'll give a little background, and then I'll let Linda fill you in on the medical complications. So I do the social work part, which is the story. Daisy was a black woman. She was tall and thin and really very attractive. She was in her early 80s, and she was very bright. Probably in today's climate, Daisy never would have been put in an institution, but unfortunately she was at an early age. And when Linda and I got to know her, she was living with a family caregiver. And Daisy was experiencing pneumonia. She had recently been treated and hospitalized for pneumonia. And all of a sudden she stopped eating and she became disoriented, not like her usual self.
Yeah.
So what was going on with her? I know I spent a few hours in the emergency room with her.
Well, what happened is Daisy was having a reaction to Levaquin, and when we sent her back to the hospital, basically, and she ended up in an admission. But the hospital staff just prejudged. They assumed that she was always like this, behaving inappropriately with hospital staff, shouting out, throwing things. None of this was normal behavior for Daisy. It was all related to the medication. And it took some convincing with the physician and the staff there to relook at what antibiotic they had given her. She wasn't on any psychotropic meds or AEDs. I mean, she basically had nothing but vitamin supplements prior to the pneumonia. And what they were looking at her as this is normal behavior and making that assumption. So it took some convincing.
And, I was, Linda had actually spent one night, the night before, I think, in the hospital with either Daisy or someone else. So I was supporting Daisy in the emergency room and talking on the phone to Linda like every half an hour, saying, well, now what should I say? But what Linda kept saying to me was, make sure they look at that piece of paper that has her med list and her functioning ability on it. So I would go over to the nurse's station, and that piece of paper, as they were doing tests on Daisy, that piece of paper kept going lower and lower on their chart. And as shifts changed and new people started working with her, I would have to keep finding it for them and saying, this is not who Daisy is. This is not how she typically behaves. Something else is going on. She's had an acute change of mental status. And I think what finally happened is the shifts changed, and a doctor came on who knew Daisy. He had taken care of her when she was hospitalized for pneumonia. And he was the one who said, okay, there's something that's changed with her, and he admitted her, and that's when they discovered it was the Levaquin.
Yeah. And what we learned kind of from that is all that paperwork we sent to a hospital with someone to help advocate for them, every time a shift changed, someone had to come in and rediscuss the case so that people were aware of who that person really was. Otherwise, they were getting buried at the back of the chart, and the one shift to the next shift never bothered to tell what the real person was. So it was a good learning lesson for us as well.
It was really enlightening. The next person we want to talk about is Robert. And Robert was a very quiet man, very bright. He had, good skills, and he went into the hospital for pneumonia. And once again, that magic sheet, that baseline that we keep talking about, that talked about everything Robert could do, ended up at the back of the chart, and nobody was looking at it.
The problem with Robert was he was a very timid man, and he didn't self-advocate well. Even though he was verbal, if he was in a new environment, he wasn't verbalizing. And what we knew from past experience with Robert is you had to make it clear that he had permission to do something, and then he was able to carry through that activity. Well, what the hospital was doing is they were bringing him his dinner tray and dropping it in front of him, but no one ever bothered to tell him that this is for you and you're allowed to eat this. And evidently that was what he really needed to hear. So he was not eating. And they were saying, well, there's something must be really wrong with him because we can't get any intake in him, and we're really getting concerned. And I said, so I went in to visit him and saw what they were doing, and I said, did you tell him he was allowed to eat this? Did you need to tell him this is his and it's okay. You can have this. And then Robert ate, and they did well with him after that. But a simple thing like by saying you have permission to do something became a big issue for him when he was in a hospital, because people just didn't realize that.
And I also think when people who have an intellectual or developmental disability are hospitalized, they're in such an unfamiliar situation, and everything that's familiar to them and known is different, and they do process things cognitively more slowly. They're not used to self-advocating, and it becomes really overwhelming for them. And you have to really maintain an awareness of that. So DJ had cerebral palsy, and he was, I guess, like almost a quadriplegic. He had very limited use of his limbs.
The only thing he was nonverbal, first off. He was a young man. He ended up with scoliosis. He was a wheelchair-bound person with cerebral palsy. And his means of communicating, his index finger and his thumb were the only two things he could move. So he could manipulate an electric wheelchair with those two fingers. He could use a chatterboard with those two fingers. Chatterboard being, just for someone who's not familiar, there was an alphabet in the middle. There was keywords on each side for basic tasks. And he can either choose to spell out a word, or he could choose, need the bathroom, need a drink. He could point to different categories. And it was a simple device. And then eventually we progressed him into a computer-assisted voice. But when he went to the hospital for scoliosis surgery, now this also was a man with no intellectual impairment. He was quite bright. He actually was mistakenly institutionalized at birth. He was a twin, and it was assumed at that time that, well, because he has cerebral palsy, therefore he will never be able to learn, so just institutionalize him, forget him. But a very clever staff realized that he was laughing appropriately at their jokes and started putting two and two together and connected DJ to educational services. And in 5 days, this very bright man learned the entire alphabet and could spell basic needs on a chatterboard. And then he came into an educational program. He was placed in a different setting. And unfortunately, with scoliosis, he had to go to the hospital for surgery. We had to convince the doctor that he was entitled to that surgery because they said, well, he doesn't walk, so what does he need this for? I said, well, because he's no longer going to be able to sit up in a wheelchair without the scoliosis surgery. And then when he got to the hospital in New York City, where nobody was familiar with him, and he was nonverbal, so he couldn't tell anybody unless he used his chatterboard, which evidently the hospital didn't consider it a very important piece of equipment, so they put it in the corner facing the wall, and being he was non-ambulatory, nonverbal, he couldn't get access to it. And they gave him a call bell that you needed an entire hand to use to press the button instead of something that was geared for someone that could just lean against it. So he couldn't even call for help. And the assumption was made because he was nonverbal that he had no capability of comprehending what was going on around him. And because he was cerebral palsy, they assumed that he should have a baby food diet, which was nothing that he ever ate, nor wanted to eat. So when we came in to visit him, that was what we needed to explain to the hospital staff there, that yes, he can talk through a chatterboard. Yes, he can communicate his needs if you put the chatterboard next to him so that he can point to what he wants. And he is continent of urine, but you have to give him a urinal when he calls for it by giving him a buzzer that he can actually use. And eventually we resolved some of those problems and got him back home after his surgery. But it was quite an awakening for everybody there, because they just made an assumption because he was nonverbal that he must also be intellectually impaired, and because he has cerebral palsy, he wouldn't be able to swallow a regular diet, which he could.
So, I think what this all indicates is that many times, because people they're just not educated about people with intellectual and developmental disabilities, they're not aware of the really broad scope of skills and abilities that many of them do have. And they're also not aware of how with really very small supports you can change the whole quality of that person's experience in a given situation. And that's why, we recommend baseline, but almost equal to baseline is establishing partnerships and communication networks with caregivers who are going to be providing supports to individuals.
Okay, aging doesn't change who a person is. We've talked about this before. As a person who is aging, still has hopes, dreams, connections to families and friends that they want to keep established. Assure that that person is included in developing and considering new and enhanced supports as they need them, and person-centered planning and principles of self-determination are the foundation for the plan and the person.
So I think at this point we're going to do a test.
You want to talk about the website?
Oh, okay, great. I jumped ahead. These are, I think we also sent you a PDF that lists articles and handbooks and useful websites, but I wanted to highlight these in particular. The Rehabilitation Research and Training Center on Aging with Developmental Disabilities is maintained at the University of Illinois. There is an enormous amount of research going on there right now, and there's also a lot of resources that are available to you just by going on the website. There are assessment tools, there are links to dementia reports and guidelines, and there's also information on meetings and conferences that are occurring where you can get even more information. The School of Social Welfare at the University of Albany, it's a state university, has a website that's dedicated to intellectual disabilities, aging, and dementia. It has a particular focus on working with caregivers and providing supports in the community. And again, the focus, there is information on people with disabilities who are aging, but there's an equal amount on how to provide environmental supports and how to work with caregivers around developing resources for people as they age and also as caregivers age. One of the things that you might find very helpful there is there's a whole article on how to talk to caregivers about their plans for providing supports going forward for a family member who has an intellectual or a developmental disability. There's an Institute on Aging at the University of Wisconsin in Madison, and this provides a lot of resources and articles and information on policies and practices in healthcare for people who are aging. There's some good PDFs for downloading. They also have a nice person-centered focus that I think is very useful. And then there's also the University Center for Excellence at the University of Minnesota. It's the Institute on Community Integration, and it also offers resources and information and training opportunities, not just for people who are caregivers, but also for people who have intellectual disabilities. And the focus is on providing supports for people who want to be more involved in their lives and more autonomous and to be very active in their communities. And just by going to these links, I don't know if they're hot on, if they're hot links, and you can just link to them. But if you go to these, you're going to just be amazed at the resources that are available. So how do we do the post-test? I think Lisa is going to explain how we do the test.
The post-test, Jill and Linda will go through each question individually, and as each question comes up, you will see something appear on your screen as a poll. And we'll do question by question, and you will just have to answer true or false. So click either one on your screen, and once the question is done, we'll go on to the next, and we'll get through the 10. And then after that, we will take questions, because I know some people have their hand raised, and we will be getting to you. So just bear with us, but let's get through the post-test right now.
Okay, the first question is, aging is classified in different ways, primary, secondary, or tertiary. Is that true or false? Okay, number 2, gender and genetics are unmodifiable factors in aging. Is that true or false? Number 3, a normal memory change is characterized by acknowledging memory loss when asked about it, but not being aware of any loss of memory in daily life. We ready to go to number 4? Down syndrome is the most common chromosomal abnormality leading to an intellectual disability. True or false? Number 5, aging makes us less prone to medication side effects. True or false?
Period. Are we ready?
Do you watch Lisa?
Okay. Number 6, chronic immobility increases musculoskeletal problems. True or false? Okay. All right. Number 7, individuals with IDDD maintain the same level of need for residential supports across their lifetimes. Can I go on?
People with IDDD are usually good self-reporters. True or false? Excessive use of psychotropic and AED meds in the IDDD population creates additional vulnerabilities as people age.
Life expectancy of people with IDDD is declining. Okay. The answers? Okay.
Okay, so we're all on the honor system here. The answer to the first question, which was?
Aging is classified in different ways, primary, secondary, tertiary.
Was true. Answer to the second question, which was?
Gender and genetics are unmodifiable factors in aging.
Also true. The answer to the third question, which was a normal memory change is characterized by acknowledging memory loss when asked about it, but not being aware of any loss in daily life, is false. Number 4.
Okay. Down syndrome is the most common chromosomal abnormality leading to ID, and that is
true. Number 5, aging makes us less prone to medication side effects. And you're the nurse.
false.
False. Okay. Number 6.
Chronic immobility increases musculoskeletal problems, and that is
true. Individuals with IDDD maintain the same level of need for residential supports across their lifetimes, and that is
false.
Number 8.
People with IDDD are usually good self-reporters,
and that is false. Number 9. Excessive use of psychotropic and AED meds in the IDDD population creates additional vulnerabilities as people age, and that is
true.
And
life expectancy of people with IDDD is declining,
and that is false. So we still have some time. If people have questions or if you have things that you would like to raise for further discussion, this is a good time to do it.
We do have some hands raised.
Okay.
We're going to start with Deb Lyons. Deb, I'm going to unmute you now so you can go ahead and ask your question. Deb?
Should we unmute this one?
Is this? Oh, no.
Jack. Jackie, you need to enter your PIN in order to be unmuted. Actually, Jackie typed it into our chat window and said, what if the person's choice includes something that cannot be done? You know, as in if I ever have to live without a pet. Not many pet-friendly settings for IDDD. Indeed, even those without IDDD, it isn't much to ask for, but if it is out of reach, how to make it okay. Second choice isn't good enough.
You know, that's really a tough one. And many times in my experience, we have had, you know, situations where people were able to keep their pets at their homes. I mean, I would really encourage you to explore every possible option for that person being able to keep his or her pet. Another thing that sometimes is helpful is if the pet can be adopted by someone who is very close to the person, a family member or a good friend, so that the person continues to be able to have contact with the pet. I know in one particular situation, a person wasn't able to keep his dog, and he was devoted to the dog. I mean, it sounds like the person you're thinking of is also quite devoted to the pet. And one of the staff at his house took the dog, and he was able to spend a lot of quality time with his dog, you know, several times a week and on weekends, and he could take the dog for walks and, you know, cuddle with him. And it, of course, is not the same as having the pet with you on a daily basis, but it is a second best. And I know as in working with people with disabilities, we always want to make things work out the best possible way, and sometimes we just can't. And it's important to realize that that is part of life. Life just isn't fair. It's not fair that people have lifelong disabilities. It's not fair that they can't always have what they want, but it is the reality of it. But I would encourage you to explore every possibility that you can.
We also had someone that I had worked with that they couldn't keep their own pets, but because their living circumstance changed. But what we were able to do for them to kind of satisfy that need to be near animals was we connected them to the Humane Society in the town they lived in, and they would go there every Saturday as a volunteer, and they would get to work with the cats and the dogs, and it gave them some satisfaction, and it was a helpful suggestion at the time.
that sounds like it was a great idea. You know, there's a lot of research that supports therapy animals, and you know, if you maybe could bring that information to the landlord. I'm not really sure what kind of a situation you're working within, but if you could make that information known, maybe you would be able to negotiate and advocate on that person's behalf so that something could be worked out. Are there any other questions, Lisa?
We have one more. No, it doesn't. That seems to be it. It was from Deb and Jackie. No one else seems to have any questions.
Okay. Well, we want to thank you for your time. It's been very enjoyable presenting to you, and I hope you found the information useful. We're going to be presenting 2 additional modules. The next one will be dealing specifically on dementia and issues associated with dementia, including arranging community supports and residential situations. And then our third one is going to be specifically focusing on aging in place. So I hope that you'll join us again. We've certainly enjoyed our time with you. Thank you.
Thank you. And if anybody has any questions, comments, or concerns after today, please, as always, do not hesitate to get in contact with me. It's Lisa at nyrehab.org or at 518-449-2976. And even if you think of something wakes you up at 2 o'clock in the morning, oh, I should have asked this question, by all means, please ask it, and Jill and Linda will definitely answer it for you. Yes.
In fact, we'd be delighted to respond. We actually think about this stuff all the time, so it's a pleasure to be able to talk about it.